Hello and warm welcome back to MedSynapse channel where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host Dr. Smarika Bhatt and today I'm honored to invite Dr. Lalitha Krishnan to the channel. Dr. Lalitha Krishnan, a prominent consultant neonatologist and pediatrician with over 3 decades of international experience, currently serving as co-founder and partner at A Second Opinion Telemedicine. She brings extensive experience from leading institutions across 5 continents. Today, she will be sharing her expertise on the topic Newborn Wishlist. The stage is yours, Dr. Lalitha.
Very good day to all present here. At the outset, I would like to thank MedSynapse, especially Smika, for giving me an opportunity to speak to all of you. Normally, when a neonatal intensivist is invited for a talk, the expected topics range from shock, sepsis, ventilation, arterial blood gases, unusual and rare cases, etc. These are no doubt important topics, but it's of interest to only a few specialist doctors and impacts fewer babies. Therefore, I have decided to choose a topic which enlists certain procedures done to babies at the time of discharge from hospital. And this will make a difference to about 25 million newborns every year in India. With fertility rates dropping rapidly, I think quality of care will trump over quantity, and hopefully the newborn wish list which I present here will help with this. Wish list is an acronym for easy remembrance of those who do deal with babies on a daily basis. Now, for generations, pediatricians have trained interns and postgraduates to check out a newborn before he is discharged home after birth. With more evidence-based care and technology, the same examination of a newborn at discharge has been expanded to include the components of wish list. We must remember that this talk is about term, uncomplicated and healthy newborns who are ready for discharge. Since they do not have an illness, we need to understand the concept of screening for potential problems that may happen in babies and what will happen if we miss these conditions. So basically, screening means to pick up problems before they become obvious or serious. Now, missing problems in neonates can result in death, mental retardation, blindness, or deaf mutism. Many a baby has gone home on day 2 of life, only to come back dead to casualty by day 7 or by day 28 of life. The first one on the list is a simple technique called weighing the baby. Now, weight of the baby is one of the easiest to measure, but very rarely done in hospitals. Now, birth weight of a baby is defined as weight taken within 1 hour of birth. On a survey that I have personally done a few years ago, I found less than 20% of babies get weight within 1 hour, and that too in an electronic weighing machine, which can be bought for something as little as 10,000 rupees and which will accurately predict weight loss in babies, which can happen in the first week of life. Now, the weight loss that happens in babies is physiological, which is mainly due to the excess water which a newborn baby has. The birth weight, which is recorded at birth, should ideally be regained by babies by day 14 of life. If a baby loses more than 10% of birth weight, that is defined as significant weight loss. Now look at this slide, which shows the amount of water which is present in ages of life. You can see that the premature baby is almost 85% of water, whereas an adult is only 60%. The newborn skin is very porous at birth, and babies evaporate a lot of water in the first few days of life. Which are the babies at risk? A study by Miyoshi showed that 399 singleton newborns, when studied, they were all exclusively breastfed, and 41% had significant weight loss. The group of mothers which were particularly at risk were the first-time mothers, primiparous, those who had an elective C-section, and an older maternal age. Now, this fits in beautifully with mothers nowadays who push their pregnancies for the sake of career, opt for an elective C-section, and are generally older than mothers were about 30 years ago. Now, among babies who have significant weight loss in the first week of life, they develop a set of complications which is very typical of dehydration, because this is similar to dehydration. They develop excess jaundice, which we will talk about later. They can develop high sodium levels in the blood due to dehydration, renal failure because of dehydration, thrombosis, shock, and even seizures. So the consequences of losing excess birth weight in the first week of life are many. How can we prevent this? First thing, of course, is to take birth weight. Second, breastfeeding should be initiated within an hour of age, at least in normal deliveries. Babies should be allowed to suckle 8 to 12 times every day from both breasts. And most importantly, the baby weight should be calculated every day till discharge. And if anybody has lost more than 10% of the birth weight, measures should be taken to compensate that. Now, if you look at these graphs, people have drawn the normal birth weight loss that is allowed in the first few days of life. Obviously, cesarean sections babies will lose more birth weight as compared to vaginal deliveries. There is also an app, because nowadays apps are made for everything, but it makes life very, very simple. You just have to input the weight taken every day for the baby. In fact, this is done in most hospitals. And if you see, the app will give you acceptable and unacceptable weight loss. You can see that this weight loss is acceptable, but this weight, which has crossed the green line, is unacceptable, and we need to do something before discharge. The next problem babies have is jaundice. Almost 80% of newborns have jaundice in the first week of life. So having the jaundice is not the problem. The problem is whether the jaundice becomes severe and when it becomes severe. So the jaundice becomes serious when it becomes severe too early. For example, if on the day of birth the baby develops a jaundice which is very severe, that would be more serious than a jaundice that becomes severe after 7 days of life, for example. Now, what is severe jaundice? Severe jaundice is the one which requires immediate treatment in a hospital. So we all need to learn what are the signs of severe jaundice. Now, this interns and postgraduates of pediatrics must clearly understand that they must learn to diagnose this entity called pathologic hyperbilirubinemia. Any jaundice which is visible to the naked eye on day 1 of life is considered severe jaundice and should be reported to superiors or the baby reported to a hospital immediately. If at any time in the newborn period you find the palms and soles of a baby are yellow, that is pathologic. when bilirubin is done, if direct jaundice level is above 2 milligrams percent or more than 15% of the total, that is pathology. Baby with jaundice showing any feature of what we call bilirubin-induced neurological dysfunction. That means the indirect bilirubin has already crossed the blood-brain barrier and it will be affecting the brain. And a sick baby who has jaundice. So these features should be familiar to all those doctors and nurses who work in the postnatal wards. What are the complications of severe hyperbilirubemia? Once the bilirubin crosses the blood-brain barrier, you can have acute bilirubin encephalopathy causing bine or chronic causing what we call kernicterus and then death. Now there is a tool because we need to screen babies before they go home to see whether they have a potential to develop severe hyperbilirubinemia after discharge. That is the whole idea of screening. Previously, what would happen? Babies would go home, come back on day 4 or 5 back to the hospital with severe jaundice, by which time it might be too late to treat patients. So this tool was developed in the US in Children's Hospital of Philadelphia. It has shown that diligent use of this tool reduces hospital readmissions and reduces morbidity and long-term neurodisability in babies. But to use the tool, bilirubin has to be assessed before discharge. There are various ways of assessing bilirubin. One is you could use what is called a transcutaneous bilirubinometer, which is a machine placed on the baby's skin, which will read off the bilirubin levels. But then, if the levels are high, the final confirmation is always done with a total serum bilirubin. And the value of this bilirubin at a particular age in life, as is shown here, will tell you whether it's severe or not and what is the treatment that should be instituted for that particular level of bilirubin. Now, this has tremendous advantages because the treatment can be started in any hospital and referred only if higher level treatments are required. We don't have to wait for any specialist neonatologist to come and tell you what to do. And it gives you an idea when the baby is leaving, whether this baby will develop severe hyperbilirubinemia or not. And we can counsel parents that we may call them back for re-evaluation. The next development that has happened in care of the normal newborn is trying to detect serious congenital cyanotic heart disease. Now, we all know as obstetricians and neonatologists that fetal echocardiography will pick up almost all heart conditions which are serious in a newborn or in a fetus, even at about 20 weeks of age. Now, not everybody will have access, or is it possible for all fetuses which are viable up to 20 weeks to have a fetal echocardiography. So fetal echocardiography is reserved for those families who've had a previous baby with a heart disease, and most other babies just get a routine ultrasound at 20 weeks for anomalies. If something is suspicious, then again they are referred to fetal echocardiography. But there will be babies, or there used to be babies who used to miss all this and then land up after birth very, very sick. So studies showed that in addition to the routine cardiovascular examination, which is prescribed for babies and is done by pediatricians at discharge, addition of pulse oximetry is a very handy tool to increase the yield of serious heart disease in newborns. Now, this enables us as neonatologists or pediatricians to refer the baby early to a cardiac center where this can be handled. Congenital heart disease, if not detected early, can be fatal. The incidence is quite high. It's about 1 in 100 to 1 in 200 births. Now, pulse oximetry can increase the detection rate of routine clinical examination for heart disease. How is this pulse oximetry screening carried out in a newborn? At the time of discharge, pulse oximeter probes are put one in the right hand and the other in any one of the feet of the baby. This is to check the preductal and the postductal saturations. If all three show that it is above 95% consistently for 3 minutes, then we know that there is probably no severe congenital cyanotic heart disease in the baby. So this, coupled with a detailed clinical examination, as has been traditionally taught to pediatric postgraduates, will pick up at least 93% of probable congenital heart disease in a baby. Again, as in the other two cases, nomograms are available, and all that we have to do is match the foot and the right hand saturations and refer for further investigation if required. Next, we come to hearing loss. Hearing loss in a newborn, which is undetected, can be devastating for the child and the family. Helen Keller said, "Blindness cuts us off from things, but deafness cuts us off from all people." Despite India's improving health indices, hearing disability remains persistently high. It is a major contributor to the loss of personal potential and a financial strain for the individual and the country. The burden is huge because it adds to the numbers each year. Thus, under 18 years of age, there are almost 3 crore students who have hearing impairment. Now, the incidence of hearing loss, which can be found at birth, is between 1 and 5 per thousand neonates. The whole idea of screening newborn deafness is to provide some kind of hearing to the child by 6 months of age. If we start activating the hearing early, then the child does not lose language potential. It is a 2 to 3 step process, so it takes time. If the baby is screened at birth for hearing and is found to have a problem, then a repeat screening is done at 30 days, and then further screenings are done. But there is no need to emphasize further that by 180 days, the baby should have some hearing process commenced on the baby. There are many causes of hearing loss. Almost half are genetic. Then there are infections in the mother, like rubella, which has now fortunately come down with schoolgirls getting rubella vaccine. Cytomegalovirus is still rampant, one of the leading causes of congenital deafness. Others like severe jaundice, any NICU admission requiring more than 5 days, indiscriminate use of ototoxic drugs like aminoglycosides, vancomycin, can damage hearing. Many of these are preventable. So as pediatricians, we have to be very, very mindful of the drugs of preventing severe jaundice in the newborn. So the screening is done by auto-acoustic emission method. It's a simple equipment which is like the size of a remote control. The probe is put in the ear while the baby is sleeping. It's not painful, and signals are assessed, and the baby either fails or passes the test in each ear. Now, this is such a simple thing to do that in India, where human resource is plentifully available, we can train auxiliary nurse midwives, we can train parents, we can train volunteers to do this, to tackle the burden of large numbers of newborn who are going home. It just requires commitment that this test must be done before a baby is discharged. The next important part of the wish list is what we call a latch score. Now, pediatricians and pediatric postgraduates will be familiar with the word latch, which in our sense, it means the way the baby attaches itself to the mother's breast and the quality of sucking that the baby does, so that the baby gets lots of milk and the mother's breast is not injured. It is very, very important to make sure that the baby latches properly so that this injury does not happen. Now, let's look at how this latch score is done. You can see on the slide that there is, and you can have a maximum of 10 points and a minimum of 0. Now, a latch score can be done only by directly observing a breastfeed in a mother, and it should be done repeatedly because the latch score changes from birth over a period of time. As the mother gets more experienced, the latch score will become better. But it is the first week of life where the babies lose weight, where they develop severe jaundice. So the latch score is very important to establish before the mother is discharged from hospital. I told you that the maximum latch score a person can get is 10. But if the latch score is found to be less than 8, then it can create problem with sustained breastfeeding. So a study found that between 6 and 12 hours of age, when you grade a mother for latch, they had a latch score of less than 8, which gradually improved, and the 99.7% who had a latch score of less than 8 at 6 hours of age, only 15% had a latch score of less than 8 at the time of discharge. And the risk factors are the same. Again, cesarean delivery, first-time mothers, later deliveries, higher education, because probably women are embarrassed to feed in the ward or whatever may be the reason, and phototherapy. So, identifying mother-infant pairs who need additional skilled lactation support at the time of discharge, which is about 15%. The latch score can be taught to them, and the mother and baby discharge only after we are satisfied with the latch score. And they found that bottle feeding or non-breastfeeding was inversely related to the latch score. A latch score of more than 8 at 48 hours of discharge resulted in a higher rate of exclusive breastfeeding at 6 months. Hence, latch score becomes important because that will help us in ensuring exclusive breastfeeding for 6 months, which is again a very, very important part and a push by the government. And mothers are given 6 months or 8 months maternity leave nowadays just to do this job. So we have to do our part as health personnel, where you ensure that the mother goes home with a good latch score on breastfeeding. The I part of the wish list: inborn errors of metabolism. Now, the word screening became very, very popular with the institution of what was called the Guthrie test, which was first described for an inborn error of metabolism called phenylketonuria, as you all may be aware. So this was done in the 40s, and it became very popular because people felt that babies who are asymptomatic could be hiding severe metabolic disorders, which if picked up early and diet was changed, there are very good outcomes. So no doubt it helped. But that became synonymous with screening of a newborn. So today, when you say screening in a newborn, people generally refer to this blood testing process, which is done on all babies in the developed countries. It's mandated by law. It's not yet law in India. It is unaffordable, unavailable, inaccessible most of the time. But certain hospitals and certain families where they have lost previous children with these diseases, definitely this is being done, which is a much better situation than it was many, many years ago. The problem is huge because our population is huge and we need to diagnose diseases for which there is treatment. So there are around 6,000 inherited metabolic diseases and we do not have treatment for more than 10 of them. So what happens is there are proponents of the universal screening who say, okay, you can screen, but what are we going to do with those that don't have treatment? And the proponents who say, let's screen, let's find out what is happening in India. We don't even know what the incidence, the prevalence, and the outcome of these babies. A lot of developmental disorders, a lot of newborn deaths, a lot of infant deaths could be due to these disorders. But the usual habits in a neonatal unit, when the child is not investigated, is brought in dread, the most usual cause which is reported is sepsis. Now, lot of it may not be real sepsis, but then sepsis is also prevalent in India. So our newborn mortality is not dropping because we are not addressing a lot of these issues. The infant mortality has dropped dramatically in India, which is the mortality in the first 1 year of life, but the period between 1 month and 12 months has dropped dramatically. The neonatal, the newborn mortality, again, remains fairly stagnant because we don't have access to all these tests. Things have definitely improved, but the problem continues to be the lack of awareness that such problems exist among doctors, nurses, and even parents. There's insufficient budget allocation for all these rare disorders. There is lack of Government of India policies presently, though a few rare diseases have gained prominence in the newspaper, where one disease treated for a few crores. Very early discharge after delivery, babies are lost to follow-up. So we cannot go after them and get blood from these babies, even if there were to be a policy. There is inadequate data. So we don't even know how many of the 6,000 we should test. So tests are available for about 62 of the known 6,000 inborn errors of metabolism. So the situation is social, economic, political, and familial, hereditary. So it's a very complex problem. But nevertheless, to a parent who can afford it, for whom this is available, and the doctor feels that the baby will benefit from doing these tests, it is definitely better that we go ahead and do these tests. And that's why I have put it down as one of the part of wish list, which means you do the test, review the test within 1 week, counsel the parents. If the baby does have a disorder which is not treatable, we can address it for the baby in the next pregnancy. So that is not a topic of today's discussion, but just want to let you know that these things are possible nowadays, which was not possible 20 years ago. So this is how blood is taken between 48 and 72 hours on a filter paper. It's hung out like a piece of cloth on a wire to dry, and all these filter papers are put in an envelope and posted to labs in Bombay, Chennai, to the metropolitan cities where these expensive machines called the tandem mass spectroscopy machines, which is shown in the adjoining picture, cost a few crores. And these are available in centralized labs, and then these disorders are diagnosed. Now, very scant data available from India, but you can see this is congenital hypothyroidism. This is congenital adrenal hyperplasia, G6PD deficiency, quite common in India. Now, this enzyme, when it is deficient, it causes a low grade or even a severe hemolysis in babies and adults, especially when certain drugs are given. But if you don't know the individual suffers from G6PD, the doctor will not know whether he should use certain drugs which can cause hemolysis. So there is a case for doing a few of these disorders, checking them out or screening in the newborn. It may turn out to be cost effective. So look at this. So looks like at least 1 in 200 babies has something. And that translates to a large number of babies when you're looking at 30 million births a year. The next most important is looking for sight in the baby. Now, we all know that babies are asleep most of the time. When they are awake, they are looking around and they have lovely black eyes. And we know that they are fine. But it may be that a doctor never gets an opportunity to see the baby when his eyes are open. So, even though there is eye testing as part of routine pediatric testing, special attention must be given to sight by doing something called a red reflex. This red reflex cannot be done by a torch, it is done by a retinoscope. And it's quite easy to perform, can be done by interns, ward nurses, they can be taught. And look at this baby, this left side is a normal red retina, and this side there is a congenital cataract. Now, if this had been missed in the newborn period, the child will lose vision very, very quickly. There are a lot of conditions which can be picked up in neonates which cause blindness. The conditions are listed there. But what is important is before the baby is discharged, his eyelids must be open to make sure the eyeball is there in the first place. Secondly, the cornea is clear. Thirdly, there is red reflex which is present. And fourthly, this thing called ophthalmia neonatorum, where there is no pus in the eyes of the baby. Very important. These things can be missed in a hurry when a baby is discharged. The government of India has brought out a beautiful booklet on universal eye screening in newborns with lovely pictures. And I would suggest at least the pediatric postgraduates and young pediatricians must have a look at this or talk to your ophthalmology colleagues about this. The last but not least, my favorite topic is thyroid testing. Now, what is this thyroid testing? There is a condition called congenital hypothyroidism, which means the baby has low thyroxine levels at birth. And we know that thyroxine is necessary for brain development. So if low thyroxine levels can occur due to various reasons, but what we need to do is test it at birth. Now, people may have this question, why can't you test it along with the inborn errors screening that you're doing? I would say yes, that is what is done in the developed countries. The thyroid levels, thyroxine levels are tested along with inborn error testing. But in India, getting a baby back at day 4 for this testing or day 3 will be next to impossible. Most of the babies will not opt for inborn error testing. So there's no question of testing for thyroid along with the inborn error testing. The best time to test for thyroxine is when the umbilical cord is cut, the blood is sent to the lab. Now, measuring thyroid stimulating hormone level in the umbilical cord is probably the best way for India to pick up its hypothyroid babies. Every year, 27,740 newborns, their congenital hypothyroidism is missed and they become developmentally abnormal. They are picked up much later, 6 months, 9 months, it's too late. The treatment is a simple tablet given orally soon after birth, and you can assure the baby almost normal development if it's picked up. So the cord blood TSH is very, very high cost benefit ratio. And it can be done for a few paise in any lab, including government, private, any lab. And if the TSH is high, a repeat formal thyroid testing can be done and treatment can be instituted, which should be done within a week after birth. Look at the cost benefit ratio in Sri Lanka, Philippines, and look at 6.91 in India. The Society for Pediatric and Adolescent Endocrinology has recommended that newborn screening for congenital hypothyroidism should be performed for every newborn in India. And this way, about 30,000 definite mental retardations can be avoided. So it becomes very, very important component of the wish list. And I have already told you why we need to do it in the cord blood, because of the logistics in our country. So to sum up everything, W, monitor for weight loss. Jaundice, keep a track of jaundice in the first week of life. Use a pulse oximeter in addition to physical examination in a baby to detect serious cyanotic congenital heart disease. All newborns should have hearing so that you prevent deafness and later poor school performance and deaf mutism later on in life. Send the mother home along with the baby with a good latch score of more than 8 so that she continues to breastfeed exclusively for the first 6 months of the baby's life. Inborn errors, right now, it's not mandated. It's a choice. I'm sure a time will come where every baby will probably undergo these tests. Check the sight. Make sure both eyes have red reflex, because this will then lead to blindness later on. And cord TSH, I've just told you about it. So friends, I think when we do intensive care, I'm being an intensivist myself, we chase after small things in tiny babies. They are also important. They need to be saved intact. But we are forgetting this large group that we let out into the community with probably serious conditions that they have or may develop. So my request is, remember that a newborn, if he could talk, he might say, have you performed my wish list? So I will end here. With this saying, we are the first line of defense in a newborn's world. Knowing is not enough. We all know, but we should apply. Willing is not enough. I want to do it. Not good enough. We must do it. Thank you.
Thank you, Dr. Lalitha, for dedicating your time and sharing incredible insights in the form of presentation. And thank you to our viewers for tuning in. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussion, and contribute to the ongoing evolution of healthcare. So until next time, stay tuned, take care, bye bye.